We'll be beginning our session with the talk by Dr. Shilpi on retinal vascular occlusions, preferred practice.
So good afternoon, everyone. So I will be speaking on retinal vein occlusions, current preferred practice. So you all know retinal vascular disorders are characterized by obstruction of retinal venous system by thrombus formation leading to retinal ischemia. And it is the second most common retinal vascular disease causing visual disability. So there is no laterality preference in these cases, and in BRVOs there is no gender preference, but yes, in CRVOs men are more affected than the women. So coming to the classification, central retinal vein occlusion is the occlusion of the main retinal vein posterior to lamina cribrosa of optic nerve. It can be present in ischemic CRVO or in the non-ischemic form. Hemiretinal vein occlusion is when one of the two trunks of the central retinal vein gets occluded. It can also represent as presence as ischemic or non-ischemic. In branch retinal vein occlusion, there is blockage of one of the tributary of the central retinal vein. It is called major BRVO when the first order vessel at the disc or away from the disc is involved, while when the macular branch is involved, it is called macular BRVO. These are the various systemic risk factors including hypertension, dyslipidemia, diabetes mellitus, atherosclerotic vascular diseases. Smoking is one of the important factors. Few drugs and other associated thrombophilic disorders like antiphospholipid syndrome, hyperhomocystinemia. Coming to the pathophysiology, with the hardening of the artery due to hypertension or the atherosclerotic changes, this central retinal artery, it gets expanded and it compresses the central retinal vein. So the virtuous stride which we always have heard, there is loss of vessel wall integrity and which causes the altered blood flow and it causes the hypercoagulable state. So it causes the blood clot in the retinal vein which causes impaired blood flow leading to increase in the intraluminal pressure, and it causes break in the blood retinal barrier which causes accumulation of the fluid, decreased capillary perfusion and retinal hypoxia which releases VEGF and the inflammatory mediators, if not tackled, then causes angiogenesis and neovascularization. So in non-ischemic CRVO, usually the patients are asymptomatic and it is an incidental finding on examination that you get there are findings of non-ischemic CRVO. Patients become symptomatic only if there is development of macular edema, or sometimes they present with the vague symptoms of blurring of vision or hemiuresis fugax. Non-ischemic CRVO has a very good prognosis, and usually if more than 50% of patients gain visual acuity more than 20/40. In ischemic CRVO, that is in the acute stage, you will get cotton wool spots, dilated tortuous retinal vein, retinal hemorrhages, hard exudates, and sometimes you also get optic disc edema with cystoid macular edema. So this is the table which differentiates how to differentiate between the two components, that is in ischemic CRVO, visual acuity is usually markedly depressed. You get RAPD in ischemic CRVO. Visual field defects are commonly seen in cases of ischemic CRVO. FFA, yes, you will get the non-perfusion areas of more than 10 disc diopters. If you go for the ERG, there is reduced B waves and reduced B by A ratio. And yes, the prognosis of ischemic CRVO is bad, and usually 60% of the patients, they develop rubeosis or NVG later in the life. Non-ischemic CRVO, even if at presentation the patient is having the symptoms and signs of non-ischemic CRVO, we should follow up these patients as the primary non-ischemic CRVO, it gets converted into ischemic CRVO in 15% of the patients within 4 months and in 34% of the patients within 3 years. So these are the two examples. This was a case of non-ischemic CRVO which converted into the ischemic CRVO after 6 months. So in cases of ischemic CRVO, if it is a chronic case, then you will also see the sheathing of the blood vessels, capillary non-perfusion areas, lipid exudation, Microvascular changes like microaneurysms and collaterals may also develop, and cystoid macular edema. Sometimes you will get atrophy of the RPE, subretinal fibrosis, and even the epiretinal membrane on the OCTs. These are the late complications like chronic macular edema and ischemia, which leads to scotoma, which is more common in non-ischemic cases. Neovascularization will develop. If untreated, it can lead to vitreous hemorrhage and proliferative diseases and can progress up to the tractional detachment or the combined retinal detachment also. So what are the important points to remember related to neovascularization? Every ischemic CRVO does not develop ocular neovascularization. The commonest site of ocular neovascularization is anterior segment. The greatest risk of developing anterior segment NV is during the first 7 months, after which the risk falls drastically. About 1/3 of the eyes with iris neovascularization and about 1/4 of the eyes with both the iris and the angle neovascularization, they never ever develop NVG. So these are the late complications of untreated retinal vein occlusion which develop neovascularization, like you will get tractional retinal detachment, vitreous hemorrhage, NVI or NVA. So how the retinal vein occlusion and neovascularization, they are correlated. So NVG is seen in 36% of the cases which develop CRVO. About 1/3 of the cases has iris neovascularization and 1/4 has both NVI and NVA. So you will also see venous shunt or collateral vessels later in the course of the disease, or neovascularization at disc or elsewhere. So the other associations with CRVO are, that is cilio-retinal artery occlusion. There are two hypotheses that it occurs secondary to the raised capillary pressure caused by the central retinal vein occlusion, or it is a primary reduction in the perfusion pressure of cilio-retinal and retinal arteries, which leads to decreased retinal circulation and subsequent the venous status and the thrombosis. Another association is non-arthritic anterior ischemic optic neuropathy. In this, there is profound decrease in the visual acuity, and visual acuity is not consistent with the retinal pathology which you are seeing. And visual field defects are a predominant feature in this association. So these are the differential diagnoses between the ocular ischemic syndrome, diabetic retinopathy, and central vein occlusion, which is usually commonly asked during the exams also, and these are the major differentiating features. The main is that on the FFA, if you see about the retinal vessel staining, in central vein occlusion, veins are more involved, yes, because it is a venous disease, and in cases of ocular ischemic syndrome, arteries are more involved than the veins. So while investigating the patient, the most important and primary thing is that you go through the history properly. So special the history of occipits in cases of females, personal history of smoking, and medical history of systemic diseases, and also the past history. So these are the routine tests which should be done in every case of patient presenting with RVO. So which are the specific tests which we should do in specific scenarios? If we see CRVO in a very young patient who is non-diabetic, non-hypertensive, think of homocysteine levels and always check the serum homocysteine levels, and in majority of cases you get that these levels are raised. In cases of you are suspecting that it is an inflammatory CRVO, so suspect with posterior uveitis or disc edema, then you should do the test related to the uveitis like Montague's, ESR, sarcoidosis and toxoplasmosis. And if it is related and associated with vasculitis, then RA factors, anti-nuclear antibodies and anti-DNA antibodies. If you are suspecting some dysproteinemia, then plasma electrophoresis is also advised. As we all know that these tests are usually very costly, so we need to clinically judge which tests need to be done and which tests need not to be done. So if there is arterial component predominance, then the factor V laden prothrombin C and S deficiency, they have not much role. So you should always check for the homocysteine levels and the antiphospholipid antibody syndrome. We also get CRVO with white-centered hemorrhages. These are commonly seen in clotting disorders, bleeding disorders, or in cases of anemias or blood dyscrasias. So this is a very crowded slide. So if we see that, yes, there is virtuous triad, there is increased viscosity, endothelial injury and stasis because of the systemic factors which leads to venous thrombosis and which causes macular edema, neovascularization and the other complications associated with the retinal vein occlusions. Now coming to the ocular investigations, visual acuity is first and the foremost, so it also depends upon the extent of the macular involvement. IOP measurement is equally important, and equally important is gonioscopy. Even if there is no neovascularization at the angle, gonioscopy should be repeated every month for first 6 months as it can develop later. Fundus examination should be done after dilating the fundus, and it should be with IO. So dilatation and tortuosity of the affected venous segment, what is the site of the occlusion, and also what are the types of the hemorrhages you are seeing. OCT is done to quantify the severity of macular edema and to monitor the response. OCTA, that is non-invasive capillary dropout areas to be seen in this, and what about we can also look at the FAZ in the patients. FFA is an invasive modality which is usually not done on the first visit of the patient. It is only done if we are suspecting retinal ischemia which is not correlating, if there are signs of vascular congestion in both the superficial and the deep capillary network. Also, if you are suspecting neovessels, and it is usually done after 8 to 10 weeks if patient is not responding. Now coming to the management, so these are the management modalities like medical treatment, lasers, steroids, anti-VEGF and surgical treatment. Medical treatment is treatment of the systemic diseases. So always take care of the systemic factors before treating the patient ophthalmically. So now coming to the lasers, in ischemic CRVO, if you get that the choroidal non-perfusion areas, capillary non-perfusion areas is more than 10 or disc diopters, then only the lasers are indicated. In cases of BRVO, if the CNP areas are more than 5 disc diopters, then only the lasers are indicated. If neovascularization develops, then you need to do the lasers. In some cases where you suspect that patient may not be on the regular follow-up, or there are more chances of developing severe ischemia, then we can also plan for prophylactic PRP in such cases. So these are the 2 studies which were done on the lasers. So they said that if the patients were subjected to grid laser in cases of BRVO, the visual acuity gain was seen. And in cases of CRVO, it does not support a recommendation of the macular grid laser. So steroids, these are the second line option after anti-VEGF therapy. Indications is macular edema. So there are 2 options, that is triamcinolone and dexamethasone implant. The most common side effect is the cataract formation and the ocular hypertension. So these are the various studies which were done. Few were done that whether the intravitreal triamcinolone versus the grid laser, and it is seen that there is no difference in the visual acuity outcomes. In cases of the CRVO, when it was compared with the observation, then it was found to be superior. And in cases of the Geneva study, when it was compared for both the BRVO and the CRVO, so DEX implants can improve the speed of visual improvement. Coming to anti-VEGFs, so the advantages is that there is significant reduction in macular edema, improved visual acuity, and decreased neovascular complications, and there are no complications related, the complications are not seen which are related with the steroid implants, that is cataract formation and IOP rise. So at present, there are only 3 options of anti-VEGFs, the FDA approved, that is 2 are FDA approved, that is ranibizumab and aflibercept, and bevacizumab, we all know it is an off-label drug which is widely administered. So these are the various studies related to bevacizumab which has shown that the letter gain is equivalent if the studies are done with the ranibizumab. This is the Berwald study, while few other studies have shown that it is not very much inferior to the ranibizumab group which is compared. Now look, when we look at the studies related to the ranibizumab in RVO, So Cruise study, Bravo study, all these studies have shown the improvement in the BCVA and reduction in the central retinal thickness at 6 months. Ranibizumab was also compared with lasers. So this study showed that BCVA improvement by ranibizumab was better than when it was combined with the laser. And also in the Brighter study, it was shown that long-term efficacy and good safety profile was seen with the PRN dosing, and there was no need of any additional lasers. Whether anti-VEGFs can be used in macular ischemia, ranibizumab was studied for that. And this was the study, that the Brighter and the Crystal study, which concluded that flexible administration of ranibizumab is an effective therapy for both the conditions, regardless of the baseline ischemic status. When we compared the ranibizumab with the dexamethasone implant, yes, we all know that anti-VEGFs are not, they don't have the side effects of which are related to the steroid implants. So the visual acuity gain was found to be superior, and there were less incidences of intraocular pressure rise or AEs related to the ranibizumab. And the Comrade study, which was the extension, they had said that the difference was more seen initially, and after the 6 months, there was no difference when even compared in the BRVO cases or the CRVO cases. So now coming to the aflibercept. So these are the various studies which also showed that aflibercept is non-inferior to ranibizumab, and it achieved the equivalent visual gain with lesser dosing in cases of RVOs. So these studies directly head-on compared the aflibercept, bevacizumab, and ranibizumab, and they clearly showed that aflibercept had similar efficacy and safety profile, but with fewer injections than ranibizumab in cases of CRVOs, while in cases of the RVOs, that is BRVO, they have similar efficacy, safety, and injection numbers for both the groups. Now, how the retinal vein occlusion is related to glaucoma? There is a strong association between pre-existing glaucoma and the occurrence of the RVO. We have seen that there is association with primary open-angle glaucoma and RVO, and also that RVO increases the risk of primary open-angle glaucoma and vice versa. So if a patient develops neovascular glaucoma, what to do? We need to, even if there is no potential of IOP, there is no vision potential, the IOP need to be controlled for the patient comfort, and also we should always treat the patient extensively by the anti-glaucoma drugs topically, systemically, and if needed, then surgical intervention is also needed. Surgical management is usually not needed in cases of RVOs, so that's why this tagline, when to operate on RVO and when to mostly not. So these are the indications when it is indicated that vitrectomy is needed in cases of RVOs: if there is a non-clearing or recurrent vitreous hemorrhage, tractional retinal detachment, epiretinal membrane formation, vitreomacular traction, recalcitrant macular edema, or neovascular glaucoma. So this is a small video which shows that there was a patient who underwent laser and also the anti-VEGFs, but there was recurrent vitreous hemorrhage in this patient. So patient was taken for vitrectomy, and there was a small prolif which was seen in the superotemporal quadrant, which was the cause for recurrent hemorrhage in this patient. So this was removed. Fluid air exchange was done after doing the vitrectomy and removing the prolif. ILM was peeled. And after doing the fluid air exchange, the fill-in laser was done and the case was completed. So these are the other indications which can be done, the techniques which can be done in cases of RVOs, but it is usually reserved for the non-responding cases like AV sheathotomy or doing the radial optic neurotomy, vitrectomy with retinal vein cannulation, with and without IRM peel, and chorioretinal anastomosis with or without vitrectomy. So what is the take-home message? We should always evaluate the patient completely. Both ocular and systemic examination is to be done. Simultaneously, we should control all the systemic conditions. Anti-VEGFs are the first choice of treatment in RVOs. Steroids should be used in recalcitrant cases and should not be used as first drug of choice. In cases of non-ischemic variant, closely watch the patient as there are chances of patients going into ischemic CRVO cases. Lasers are done to the ischemic areas when there are high risk of developing neovascularization. In cases of complications, yes, surgical management is needed. Thank you so much.
Any questions you have? I remember a long time ago, we used to read that following the central retinal vein occlusion in one eye, if the intraocular pressure in that eye is low, the chances are that it will develop glaucoma. Immediately following the CRVO, if the intraocular pressure is lower than the normal eye, which has no vein occlusion, the chances are that this eye will develop neovascular glaucoma. How true is that statement? Also at that time when there is vein occlusion, which reduces the ciliary secretion and therefore reduces the pressure, the associated arterial occlusion in turn causes ischemic changes. Was my explanation. Is that still true or it's not true?
Sir, we haven't
It has
observed
not
that,
been
but
observed.
yes,
Okay.
if there is a combination of the vascular and the arterial occlusion, the prognosis is real bad.
Use the mic, Raju. Just give me a mic, please.
In most of the cases of ocular ischemic syndrome, because of the involvement of the artery, there is a decreased, as our chairman has pointed out, there is a decreased secretory occurring from the ciliary body. So it doesn't cause the secondary glaucoma. That is one reason. And the second thing is that if there is a combination of CRVO and arterial involvement, then also this factor comes into action. That may be the reason why there is no increased intracranial, IOP pressure in that one. The other question which I wanted to ask you is about when a patient presents with an acute central retinal vein occlusion, if he has an RIPD and ischemia and macular edema, what will be the evidence-based approach to such a patient? Will you go in for a laser treatment or anti-VEGF? What is the evidence-based support for that?
Sir, anti-VEGF is the first line of treatment if there are, even if it is a ischemic CRVO. Because of the, there are the hemorrhages and everything, you cannot do the laser. We should wait for the clearance of the hemorrhages, and then if needed, then we can do the lasers at a later stage.
Okay. Thank you very much.